on?
So as I was saying, we take advantage of the particular features of the TMJ, both in opening the patient's mouth, which is the hinge part of the joint, and pulling the jaw forward, or in this case, up. I like to think of the mandible as being the handle that holds the tongue. So the base of the tongue, you're actually pulling that base of the tongue as you get behind the patient's mandibular ramus, which is the back part of that 90-degree angle that the jaw forms, and pull that ramus straight up like you were lifting a curtain. You open the patient's mouth, you pull the jaw up in the air, and what that does is it creates space so that there is airspace behind the tongue and the posterior pharyngeal wall. It's much different than just pulling the chin up like this, because oftentimes what that does is it displaces the tongue against the palate, and in small children, especially if they have dry mouths, their tongue adheres to the palatal surface and completely occludes the airway. Oftentimes their nose is occluded, small, has mucus in it, and doesn't provide the kind of good air passage that you need. So again, the maneuver for me is I hold the chin with my thumbs, and I put my fingers behind the mandibular ramus, and I simply pull up and out. And you can do that with a mask as well, by getting your fingers behind the mandibular ramus. Use the mask to open the mouth by pushing down on it and lifting up and out. That, I think, is the most effective way of creating an air passage. So why do we have airway occlusion? Oftentimes, we receive patients in the recovery room, or we as anesthesiologists deliver you patients in the recovery room who are still anesthetized, hypotonic. They're in this supine position, which tends by gravity to cause the tongue to fall against the soft tissue. Sometimes that can be relieved by turning the patient on their side, so the gravitational effect of all of that relaxed soft tissue is less, and the tongue can fall to the side, creating a better air passage. But if you're nursing the patient on their back, you need in some way to relieve that and open that airway. And again, I think that opening the mouth and pulling the mandible really straight up to the ceiling is the best way to do that. So that's a form of airway occlusion that's simply created by normal soft tissue relaxation. The other airway obstruction that we often encounter is laryngospasm. And this is an actual muscle spasm that involves the vocal cords, and it's a protective mechanism in most respects. We have two ways of protecting our lungs from foreign material entering it, whether that's water, saliva, blood, or aspirated food. One is the epiglottis closing over the glottic opening. That's a normal part of the act of swallowing. So every time you swallow, your epiglottis works as a flap valve and closes over the glottic opening so that food can go down into your esophagus without entering your airway. We don't even feel or think about that as a rule. Laryngospasm is a much more vigorous protective mechanism. And often it's a detrimental mechanism that is a spasmic closure of the vocal cords by a spasm of the musculature that controls those tissues. It can be generally caused by any kind of material that in a partially awake patient stimulates the vocal cords. So it usually doesn't happen in a patient who's deeply anesthetized. It happens in patients who are in the process of either becoming anesthetized or emerging from an anesthetic state. So they're in a state of hyperreactivity at that point. Saliva, blood, and even the loss of airway patency. So if you have a patient who has developed an airway obstruction simply due to soft tissue relaxation, and they're trying to expand their rib cage and their diaphragm and work to breathe, sometimes they actually can pull tissue into their glottis as they're trying to move air, and then laryngospasm will develop as a result of that. So it's always better to prevent airway obstruction than to try to treat it. And sometimes you can get into a really bad spiral of airway compromise that you can prevent by maintaining an open airway from the very beginning. Laryngospasm can be definitively treated by muscle relaxation. So if you deliver a dose of succinylcholine or another muscle relaxant, you will for sure break laryngospasm. Then you also are confronted with a paralyzed patient at that point. Our first maneuver to try to break laryngospasm is to apply a significant positive pressure to the airway. I won't be able to demonstrate that with this mannequin because the air will just run right down his throat. But if I close this valve,
so you have totally closing the circuit, right?
Completely occluding the circuit. So this valve is completely closed. I'm putting this on the mannequin's chest just to simulate a relaxed airway. I can do that.
I put it on my belly.
So I'm generating here what looks to be 40 centimeters of water. And it doesn't matter how high the pressure is. If the laryngospasm's not broken and you're not moving air into the patient's lungs, you're not going to be injuring anything. So you want to have as much pressure as it takes to break that laryngospasm. So as tight as you can make this bag, as tight as a seal, is what you need to be effective.
Does that usually take two people?
Often it can. Usually when we're in the, we have a lot of experience at managing the airway. So for us, even sometimes it takes two people. But most of the
Can you show us
time,
what that would look like?
what two people would look like? Yes.
Two people ventilation.
So one of us, maybe Rhonda, would hold the patient's mask, and the other operator would be squeezing the bag. And again, we're not doing this effectively. Well, we're actually achieving pretty good effective ventilation. But if this patient were laryngospastic, that air would not be entering the lungs, and we'd have to really squeeze on this. What you're doing is literally mechanically pushing the vocal cords open, just like trying to open the doors of a stuck elevator. I mean, you're just trying to spread those apart. And it's a little bit like that phenomenon of trying to open the blade of a jackknife. When you get it past a certain point, then everything relaxes. So again, that's the idea. Can also break laryngospasm by deepening the anesthetic state with a dose of a drug like propofol, a rapidly acting hypnotic that deepens the level of anesthesia. But by far the quickest and easiest maneuver without running for a syringe and a medication is to apply positive pressure to the patient's airway. It's easy to recognize airway obstruction because the patient's breathing or attempting to breathe without moving air. So you'll see respiratory efforts being made, but retractions of the tissue above the manubrium, the patient's not moving air, and yet their chest and diaphragm are moving vigorously in most cases. One final thing that I should mention is that airway obstruction with a patient actively attempting to breathe can often result in a complication called negative pressure pulmonary edema. This can be from a patient biting on an endotracheal tube when they're breathing, when they're trying to move air. They're partly awake, they're intubated, and I might also add that this can happen with laryngeal mask airways. If a patient is allowed to awaken to the state that they can bite on that airway device, they will occlude that airway and yet be vigorously trying to breathe. And what that does is creates negative pressure inside the alveoli, and it draws fluid from the pulmonary capillaries into the alveolus and causes the exact picture of pulmonary edema that you would see from any other cause, such as heart failure or anaphylaxis or anything of that kind. So it's really important to recognize that as well. It's important to break or reverse any kind of airway obstruction, not only for the hypoxemia that usually develops, but also that pulmonary edema complication as well. Anything else you guys can think of?
So if you've got a patient into the recovery room and you noticed right away that they're starting to obstruct, what would be one of the first things that you would do?
The first thing that I would do is position the patient's mouth. I mean, that's more important than applying supplemental oxygen or anything. Again, that maneuver is mouth open and jaw forward.
Okay.
You know, it doesn't hurt a patient to literally lift their head off the bed in doing that. And we do that a lot. It's exactly the same maneuver that we do with a laryngoscope when we put a laryngoscope into the side of the patient's mouth, behind the tongue. We're literally using that device to create space behind the tongue so that we can see and place an endotracheal tube. You do the exact same thing with this airway maneuver. You open the mouth and you lift the tongue away from the posterior pharyngeal wall, creating space. In one case, we use it to see things and to put a tube in there. In the other case, you know, you're using that maneuver to create space for air movement.
And then if that didn't work and your O2 sats continued to drop, you would probably want to grab your Jackson Reese or your airway
I mean, as long as you're
and
able
apply some oxygen.
to open the patient's mouth and do that, I think always supplemental oxygen is an important thing in an airway obstruction situation.
What
But,
about an oral airway? When would you want to use that?
that, I think sometimes an oral airway can be appropriate if the patient's anesthetized enough to tolerate it. Sometimes putting an oral airway in can actually stimulate laryngospasm, so it's, you know, if you're able to put an airway into the patient's mouth and they will tolerate it, it's probably okay.
No response.
If they start to gag or bite on it, it's better just to abandon that. Yeah.
Okay.
And then maybe just show us a little difference in how much easier it is to open the baby's airway versus a child's airway.
Well,
Or an adult.
Or an adult. Like
the anatomical principles are identical. Obviously, the spaces in the infant airway are smaller. They are probably more prone to laryngospasm than adults. Their tolerance for any period of hypoventilation is less. They become hypoxemic much quicker than adults. So those are all important considerations. But I really manage infant airways in every way the same as I do for older children and adults. You know, really get behind the mandible, open the patient's mouth. Oftentimes their nasal passages are even, you know, less capable of air movement than adults, but certainly air flows through there as well. So again, it's behind the mandible, open the mouth, lift.
And they're pretty small. Do you find it relatively easy to manipulate?
Yes,
Okay. So you just reach over and open it. Very gently just push those mandibles forward.
that's it.
Okay.
All right.
Thank you very much.
Thank you.
It's a pleasure.
Thank you.
Thanks for helping us.